And so I'd like to kind of turn back to the case and go back to Greg and see what your thoughts are on this patient who really doesn't have a full genetic and immune profiling from her adenocarcinoma.
So the tissue always is the issue, apparently, but we in most laboratories generally have a cutoff for 20% tumor content for any of these type of sequencing-based assays, with the idea that a heterozygous mutation you can then detect it at 10%, and most of these assays are validated down to at least 5%. But obviously we're trying to push the limit sometimes. In these cases when we're getting tissue and what gets sent. So there are cases, we see it relatively routinely with foundation medicine where they'll call some of the mutations, but they're not able to calculate the tumor mutation burden or the microsatellite instability, and they'll kind of put it out as a qualified report. So just so you're aware that you're potentially there could be missing some driver mutations. The other thing that actually we've published, and also MSK this year, is that when you're doing this sequencing, you're not only sequencing the tumor, you're sequencing everything. So you're sequencing the stroma and the hematopoietic compartment. And so especially with a lot of these older patients and patients that have been on chemotherapy before, that they have often clonal hematopoiesis of indeterminate potential, potentially, and that can be picked up on these sequencing assays. And so, if you see something like DNMT3A, especially, that's something to be aware of. But about other things like P53, that you don't really necessarily know where it's coming from. And so, the thing, you're also picking up germline alterations, and sometimes I think with Foundation's algorithm, they'll fail certain specimens, but occasionally if something pops up on their germline calling algorithm that they think is potentially in the tumor, they might put that out as a real, unqualified report, and just another thing to kind of be aware of when you have to interpret these reports.
So Ben, in this case, when you have no genotyping, what do you do?
This is an all too common scenario, unfortunately. I mean, much of my clinic is sometimes second opinions where we're trying to get the tissue over, or sometimes we're doing the biopsy and we don't have enough. I have routinely used a plasma genotyping platform in these patients for treatment-naive patients, in which we have the tissue that's made the diagnosis of lung cancer, but there's not enough tissue for molecular interrogation. Of course, we can't get PD-L1 off the blood, but I think there is a role for plasma genotyping in these patients in which we have a diagnosis of lung cancer, but the tissue is insufficient. I think there's a role, and the turnaround time for these tests is anywhere from 5 to 7 business days, and you're trying to get going on a therapy. I think the presence of a mutation when you find them in the plasma essentially rules in, given the high specificity and the high positive predictive value. I think the absence doesn't tell us much. I think we need to default to tissue. So in these patients, when tissue is insufficient, and if this were my patient, I would default, even though the patient's a current smoker and may be unlikely to have an actionable mutation. I would consider a plasma genotype to try to identify a targetable mutation.
Mm-hmm. Paul, your thoughts?
Yeah,
when would you test?
I agree. I tend to test increasingly more often, and I tend to do things simultaneously now because there really is no downside. Part of the benefit is that, at least at Memorial, we have an in-house ctDNA test that we can rely on. And of course, I think preferentially we'll try to get a tumor biopsy done for complete testing. But in a case like this, where it's clear that the patient has rapidly progressive disease, there's not going to be a lot of time to refer them to IR to get a biopsy done, then as you, I think, prep them for what the next systemic therapy is going to be, plasma genotyping really has a big role here to play.
So she's gotten carbopen-pembro for 4 months and has rapid progression. Do you rebiopsy? Do you do plasma testing? What are your thoughts?
If the patient hadn't had plasma genotyping or any molecular interrogation up front, I think there's a role for, it's tough to do a rebiopsy on a patient who's rapidly progressing. I think we all know that. So for me, I would probably do it then. If I hadn't done it from the start, I would probably order a plasma genotyping.
I would also. Yeah, and then hope maybe that you get some period of disease stability later on the second line of therapy to be able to get a formal biopsy if the plasma genotyping ends up being negative.
Yeah.